Jess Williams, who's Director of Commission for Tameside and Glossop Strategic Commission. And Jess, I think, is going to open the slide deck for us tonight. So thank you. I'll leave you to Jess to carry on. Thanks very much.
Okay, thank you, Andy, and thank you, Lee. So yeah, short presentation, and as Andy has said, this really is a listening event, so we're mainly interested in finding out what this is feeling like and meaning for you. So it is only a very short presentation. In fact, I think we've got it down to about 7 or 8 slides. So what those slides are going to do is just talk about why there's a boundary change, what the change means, what we've been doing up till now, and then we'll move over to you and to understand what matters to you, and then be able to hopefully answer as many questions as possible. But then also, if we need to ask others to come in or feedback later on, then that's what we will do. Okay, so next slide, please, Lee. So why are we changing the boundaries? So with the creation of integrated care systems, there was a decision by the government in July 2021, so last July, that there would be a number of CCG boundaries that would change. And the purpose of that is to align health with social care predominantly. And that's really where the benefits of this comes from, because it's about the alignment being able to create some more joined up working across health and social care, and also the wider prevention agenda, and also the wider public sector. So it really is about trying to get prevention, which is and population health, which are normally addressed by councils, to work much closer with health services. And so therefore, as one of the 4 CCG boundaries which is going to change, the decision was made that Glossop will move from where it currently and has traditionally been for the last 20 odd years, from Tameside and Glossop CCG, so part of the Greater Manchester health system, which you can see on that map shows the boundary in red, and that Glossop will then move into the current Derby and Derbyshire area, and in their future ICS, which is the blue boundary line. So if you see now, that Glossop is currently within the red, and if you take away that red line, the boundary between the Derbyshire and the Derbyshire ICS will now be where that blue line is. Now, originally the plan was that was going to happen on the 1st of April, but due to the parliamentary process being slightly delayed, there is that's now going through Parliament. So the white paper has to be enacted before these boundary changes will happen. So the delay is currently 3 months, and the proposed change will happen on the 1st of July 2022, all being well. So next slide, please. So what do the changes mean? So the first and possibly the most important thing is that for patients and the population, you shouldn't experience any difference in the way you receive NHS services. There are not planned to be any changes to services for the next 12 months. The population of Glossop and elsewhere in Derbyshire and Greater Manchester can continue to access all of the same services as they do now. Care and treatment is going to be delivered in the same way that it is now. And patient choice will obviously still apply. It's one of the cornerstones of the principles of the NHS. There will be some back office function changes. So, for example, the money will flow in a different way. So instead of the money which is associated for commissioning services for the residents of Glossop coming into the Greater Manchester system, it will now go into the Derbyshire system. But Derbyshire will continue to fund the current provider of services, and those services will be provided in the same way that they are now. Derbyshire have also committed that in future there may be some changes which work better for the population or make sense either economically or any of those other reasons, but they've been really, really clear that there is a commitment to make sure that all stakeholders are involved right from the start, and that there will be a co-design based approach to thinking about how those contracts and move in the future. That doesn't mean any of them necessarily will change. Many of them probably won't ever change, but there might be some that do, and those will be done in conjunction with the population of Glossop and on that co-designed approach. And so really, overall, the NHS changes are to try and ensure that we continue to improve our services, and bringing Glossop health services closer to social care and that wider public sector services aims to address just that. So that's about the funding. Next slide, please. And I think, Kate, you're going to take over from me now, aren't you? Go for it.
I think that's right. So since the announcement, what we've been doing is working through jointly, and all of the work streams and all of the pieces of work that are happening behind the scenes are very, very much joint between the CCGs, both of the CCGs. We've been reviewing all of the contracts, and it's quite surprising that there are so many. We often think about the big hospital contracts, but there are in fact just short of 200 contracts in total. But it's important to remember that Derbyshire will already have contracts in place with many of those providers, because there aren't borders, there aren't boundaries, people move and access services that closest to them. There's lots of commitments within the NHS about choice and people being able to go, particularly for elective care and as referred by their GPs to providers across a wide range, and people do now. And so many of those contracts, Derbyshire will already hold contracts, and therefore it's about saying, but the additional element that needs to then, the funding that needs to move so that Derbyshire will have the funding to continue to secure those services, is the detail that we're working through. We're also trying to identify where there may be differences. There were some elements of the NHS that are really core, and nationally they're set in the ways that we commission. It is a national health service, and there's lots that's very centrally directed, and so there's very little difference. But there are some elements where local CCGs have had some flexibility, and so things like primary care and how some of the additional funding that flows to primary care is set up might be slightly different, and so teams again are working to identify what those differences are. And part of that also means that there's relationships are building up, people are getting to understand those differences and learn where there may be opportunities and aligning. So we're constantly reviewing and how things happen in the NHS. So there's opportunities to really learn and to think about longer term how we might shape some of those ways we do things and learn from each other. There's also some practicalities about data access and control. So each CCG as a commissioning organisation is very limited in terms of the access it has, and it makes sure that it only can access any certain levels of detail for patients that it commissions for. So again, there's some technical arrangements to make sure that the information flows will be there to support the commissioning of services from the Derbyshire system for Glossop residents. And making sure that all of that financial flow work, there's lots of core things that are really evident. And then there's smaller elements, there's grants and arrangements, there's some of those community elements that I'm going to come on to talk to about in a moment that aren't so obvious. So we need to get to quite a level of detail to just understand that. But again, whilst the changes will happen in July, a big border won't go up. There's constant ongoing work, and the opportunity for us, if as we work through this over the next year, we identify some elements that we didn't pick up in this first way of working. We've got agreements between ourselves as colleagues to just make sure we pick those up, manage those risks and address them. So there isn't a sort of big guillotine comes around, and if we haven't got it all right by that point in July when we transition, it's no going back. But if we discover that there's things that we've missed as we work through this, we've got arrangements for how we will take that forward as we move on. If we could move to the next slide. One of the things that's most important, though, is understanding, as we're doing today, what matters to you. And the element that I'm responsible for in terms of community commissioning development is around those community services and those links. And as much a part of the service family are those local voluntary sector arrangements, those local neighbourhoods. And we've seen that more and more in COVID than ever before. And it's really important that we're building on those, understanding those and connecting those two. So we're working with community and patient reps to hear what matters and what's important. We're trying to work with staff, share updates, because The staff are the front line who are hearing what's of concern to people. So we're trying to provide information to staff and listen to staff about what issues are arising. As I say, continue to work with primary care colleagues and the wider services in the local area, and particularly from my perspective, building those relationships with health and social care, voluntary and community sector. As Jess said, the changes are being driven so that the backgrounds are all aligned, so that health and social care are working from the same footprint and working between health and social care and those statutory services and the local community and the voluntary sector and the neighbourhood arrangements there is the biggest opportunity as we move forward. So we'll get all that detail arranged in the background, but then look at what the opportunities are on the ground. And I know from workstream I've been involved in the great work that's happened in Glossop, the real community energy that there is, and the really engagement that you have in the patch that we really want to again make sure we maintain, build on, and learn from as we move forward together. But as it says on there, this is about background work. The real work starts in July, about how we look at what those opportunities are. And it's important to remember, services have been under so much pressure in terms of responding to COVID. We're coming out of that now and trying to build on that recovery, look to longer term transformation, build new ways of working under the integrated care system, and neighbourhoods, places and aligned health and social care are a really important part of that, which is why this change will give us a really good opportunity to make the most of those national changes when they fully come into effect in July, or start to come into effect in July. So really, I think that was all we wanted to set out. As we said, we wanted to really make sure it was very minimal input, and that then we gave opportunity to hear from yourselves and to start to gather as much information from this sort of session and the other ones that we've had that we can continue to respond to in different ways. And I think comms colleagues who are on will explain if anybody needs to about things like the information that's available on the website and how we're gathering and building this information. It's a conversation, not a one-off opportunity. So we want to really hear the things that you might be concerned about, the things you want to address, or opportunities you want to flag to us for how we can make the most of this moving forward. So I think over to you is the next slide, and I think that's what we'd like to do. So I think in terms of questions now, I think as Andy said at the start, there's a few other people in the audience here today who'll be able to pick up particular questions if there are specifics. So I've not seen so far that there's questions gone into the chat, but for those of you that weren't on right at the start when Lee outlined it, if you want to use the raise hand function, which is where the smiley face and the hand is at the top on the bar there, then we can start to pick up questions. So I can see the first one from Katie. Do you want to come in, Katie?
Hi, yeah, thanks so much. So I'm Katie, I'm representing Parkinson's UK this evening. It's great to listen to the presentation and understand that there's going to be a real opportunity for local communities and local residents to help shape services. But one of the things that we have noticed is that the communication from sort of frontline staff isn't that clear at the moment or reassuring, particularly for people with Parkinson's who have a neurological condition. Anxiety can really flare symptoms up and can really impact mental health. And as an area development manager working in Derbyshire, I know of concerns from patients who haven't had quite the positive reassurance that you're conveying here this evening about services. And a secondary element is that in Derbyshire, particularly on the Parkinson's service, it's at crunch point at the moment. Capacity is a definite issue, particularly with kind of patient choice. We have a lot of people already referring in, and Parkinson's, as many other conditions, is expected to grow kind of 20% by 2030. So it's two things really. One is I think the messages from staff in our experience, what we're hearing from personal experience, hasn't actually been that positive, clear or reassuring. And the second thing is that it's really important that when we're looking at service design pathways, that we are actually looking to future-proof instead of lurching from sort of one crisis to another. So that was kind of the feedback from our community that I'd like to share.
That's really helpful feedback, and I'm sure, I don't know, Andy, whether there's anything you'd want to comment on in terms of those staff messaging, but certainly that's really important for us to hear if some of those messages aren't going through, because if people aren't then conveying the no change, and that's causing anxiety, we'd really want to address that, because there's no need for people to be raising concerns or to be unable to assure patients, and so we really wouldn't want that. In terms of your wider point, yeah, couldn't agree more in terms of being able to plan ahead, and a particular focus, and I think the focus that integrated care systems give us on particularly that older population, where they've got health and social care input is, I mean, there's lots of sectors and cohorts of patients and people living in communities where the joint working is important, but I think for the elderly it's particularly evident. So I think there's things that we would want to be able to work together on, and work with representatives from the patient groups and cohorts and populations to build on as we start to strengthen things going forward, as I completely recognise the challenges you're flagging there. I don't know if there's anybody else wants to come in and comment on that. Leslie, did you want to comment on that issue? Yeah, come in.
Yes, please, thank you. I know the team have actually talked about this, and one of the things we have raised is about the confidence for staff. And it might not be what they're saying, but whether they feel confident enough in the way in which they're saying it. And that could be very subtle, really. And that's one of the things that we have talked about. It's about getting the messages through to the staff, to be sending the same messages to their patients and the public that is going out generally. And I think it's difficult for staff because they've got all sorts of varying worries. And I'm really pleased to hear the one that's just been raised, because it exemplifies so well things that are easily missed. But I do wonder whether it's a very difficult one. I don't have an answer for it, unfortunately, but I would like us to look at it further. Thank you.
Yeah, I'll bring Andy in there. Do you want to comment, Andy?
Yeah, almost debating what Leslie just said, actually. I've put for Katie, I put my details in the chat box because it'd be really helpful to speak direct. I think if we know what is being said and whether it's a nuance or whether it's just people feeling as staff members concern themselves, either way or both ways, we just need to address that. And as Leslie said, it's something we're already trying to do and briefings have gone out, but if they're not quite hitting the mark, then really helpful to know what we're missing or what we can do differently. And I'd really welcome a chat if that's okay, Katie.
Lee, do you want to come in?
And I was just going to add to that off the back of Andy and Andy putting his email in the chat box. We have got, and I'll drop the link in because we put it in the presentation, kind of a central hub for everybody's concerns that we're collating into what we're calling a listening document, and that goes for kind of public and the staff as well. What we're doing is collating the comments as they come in, be it via social media, be it via meetings that we have tonight, face-to-face things that we might be doing out in the community, hopefully now that things are dying down with the pandemic, or things that have just come in via phone or email. So we're theming all of those. Even if it's already been raised, we're adding that it's been raised a few times, and then that gives us, as a kind of service point of view, a bit of an idea as the strength of feeling. Not that any one single comment would ever be ignored, but please do all kind of speak out if you have points like that, because it really helps us build that document up. I'll put the link on in the chat to where that document sits, but we'll be evolving that over each of these sessions we have, each of the times that we collate more data towards it. So yeah, thanks.
Thank you. And I can see a question in the chat there about trying to understand who or where the proposal came about, Glossop, the change. I personally don't know. I don't know if anybody here. My assumption is that it was a sort of national drive around aligning where were an identification of areas where the health boundaries and the local authority boundaries weren't aligned, rather than it being proposed. But I don't know if anybody else has got any. But John, I think it's your question. Do you want to come in, and then we'll see if anybody can answer that, and also the second question about consultation. John. You're on mute still, I'm afraid.
Well, yes, when they were first created, local authority boundaries and health PCTs were generally coterminous. And the exception was Glossop. The very sensible suggestion was that Glossop and Tameside were together in GM. This was decades ago. and that's eminently sensible. I mean, I happen to live about 2 minutes from Woolley Bridge. I'm in the northwest corner of Derbyshire. I actually live in Hadfield near Glossop, and it takes me about 30 seconds to get into Tameside, into Hollingworth. So, you know, it makes eminent sense. And my main question is, if it ain't broke, why would someone want to fix something if it ain't broke? Sorry to be a bit crude there. Tameside and Glossop PCT work very well, and my elderly neighbours have been to Tameside Hospital. I've taken them today. They're going tomorrow. So Tameside Hospital is about 4 miles away, and you say there'll be no change, but you know, I wonder if this is going to develop. You know, my people that don't drive. We're in an interesting part of Derbyshire. I mean, we've got Northwest Ambulance Service. We might have Glossop Fire, for instance, and Glossop Police, but we've also got Northwest Ambulance Service. We've also got United Utilities Water. We've got Northwest Television. We are on the northwest corner of Derbyshire. And I'm just wondering in the future if there'll be any push, say, to people to use hospital services in Chesterfield. I mean, people in Glossop, some people in Glossop have never, ever, ever been to Chesterfield. That's 31 miles away. Or the City of Derby Hospital, which is 52 miles away. I'm just a bit sceptical about where this will eventually lead. At the moment, it ain't broke. Glossop and Tameside work together. We've lost 2 hospitals in the last 40 years. That's Woods Hospital in Glossop and Shire Hill. We've got developing health facilities on George Street in Glossop, and I hope they do get developed. But I'm just wondering what the objective is. What's the aim of this ultimately? We are in the northwest corner of Derbyshire. It's much quicker to get to the city of Manchester, Piccadilly. It is to Buxton, where we live, for instance, and there's a direct train. Very hard to get to Buxton from here. We are in the northwest corner and we're in the northern High Peak, and we are very much joined to Tameside for major health care. And it's, as I say, it's 10 minutes when there isn't much traffic. It is 10 minutes to get to Tameside Hospital. And what ultimately is the aim of all this? That's my question.
Jess, you put your hand up. Did you want to come in to respond to that?
Well, I'll come in. I'm not sure I'm going to be able to address all of John's comments because what ultimate aims are, of course, I'm probably not privy to know, but I can tell you about this bit. So the first thing is that no patient who currently goes to Tameside won't still go to Tameside. Tameside Hospital has about 85% of all of its activity come from the Tameside and Glossop area, and about 15% of it come from Stockport, people from Manchester, odd people who were on holiday somewhere in GM, and a whole bunch of people from Derbyshire. Derbyshire already have a contract with the hospital, the Tameside Hospital. So basically what happens is we will get less funding, Derbyshire will get more funding. So that's in terms of CCGs, but the hospital will still have the same amount of funding, because instead of me giving 200 million to the hospital, I'll give them 180. And instead of Kate giving 200 million, she gives them 220 million, if you see what I mean. Those aren't the right figures, but you get the general drift. So the patients who choose to go to Tameside Hospital today, in future, can continue to choose to go to Tameside Hospital. There already is a contract, so there shouldn't be any issues with that. So, but the hospital has already and has been delivering for the last 5 years the community services for Tameside patients and for Glossop patients. And that is where it is slightly different, and it's slightly different now. So the community teams who work with the Tameside Council services have to operate in one way because they're all on the same footprint, but we've had to put in some workarounds in terms of how the Tameside Hospital community team is able to engage with population health and the various council services up in Derbyshire. It hasn't made it any worse, but they have been different workarounds, and that is the area which with this change should improve. So there should be improved data flow, there should be better communication, there should be better connection from health with public health. You should be able to improve relationships between, cement relationships so that the Glossop adult services team and health visitors are able to work much closely together, etc. So there should be some advantages that come out of this, and there shouldn't be any disadvantages. That is the plan. But I take your point about where this ultimately ends, but I would be astonished if Derbyshire didn't choose to continue to have exactly the same contracting arrangements with those large, big providers, because as you rightly say, it's where the people of Glossop have always gone. And I thought it was 23 years, but somebody did tell me they thought it was longer than that. Yeah, so I mean, there's things like the primary care network. So the Glossop primary care network, I think there are advantages for them about how they've already started work. They already work very closely with the Bureau and other voluntary sector groups, but there are probably some enhanced ways of bringing them closer with the social care services as well. So that's the advantage, and there shouldn't be any disadvantage. George Street is another issue, and I think is something where the community may want to influence where that direction goes in future, because there is a small amount of capacity in there and things will change over that, and it might be that you want to move other services into that area as well, because it is a great facility. We only managed to fill it about a year and a half ago. We hadn't been able to fill it up until then, but there are gaps and there are challenges for us in terms of dental health care and various other things, which there could be opportunities around George Street for that in the future. So I'll stop there, Kate.
Thanks, Jess. And I know Linda's probably came in with a hand first, but I'll bring Helen in, because I think, are you planning to respond on that point as well, Helen?
I was, if that's all right, Linda.
Thank you.
Kate, yes. And I guess it's a really interesting question you raised, John, because I guess if we think that this agenda is all about health and the NHS, then the question makes a lot of sense. I mean, it makes a lot of sense anyway. I guess for me, this agenda, and I'm Helen Jones, I work for Derbyshire County Council, so I work in local government, and I know for NHS colleagues here tonight is also about what we call the wider determinants of health. So it is about ensuring that people have a good, healthy life expectancy, that people have a good life expectancy, and all that work you people here tonight do in communities, all the work the community and voluntary sector does is as important as those services that provide treatment in the NHS in terms of those things. And so I guess the direction of travel from government here in terms of the development of the integrated care systems and the thinking about those care systems being coterminous with local authority boundaries is because the job we have to do in terms of improving people's lives, improving people's life expectancy, improving people's healthy life expectancy requires all of those partners to work together. So that was the kind of national direction of travel around coterminosity. It was about starting people's communities with all those things: smoking cessation, obesity, space for people to be physically active in a safe way, homelessness, etc., all those things that affect people's health and well-being are part of this agenda. And actually that coterminosity of boundaries that we've now got in the integrated care system in Derby and Derbyshire is seen to be an easier way of working that and making it work. So I hope that just adds something to answer your question, John.
Thank you, Helen. And I'll bring in, I think it's another question, and I have spotted, Sonia, that there's part of your question that still needs answering, but if I bring Linda in next, please.
I just came across this just by chance, and my understanding is that I understand the need to integrate social care and health, and that's the longer term plan. And my understanding is it's a central government, no doubt, a very keen civil servant that thought this was a marvellous idea initially. I know that our local MP objected to this. Not my only concern, one of my concerns is the language. And I worked in local government for a long time, and I also worked in central government. So maybe I'm just old and cynical, I don't know. But the language of for 12 months, there'll be no change. Well, then what? And whilst at the moment, things have been good in terms of people saying, oh, we've been like this for 23 years and financially it's about moving money and you'll still be able to use the services that you direct. We would be naive to think that that would be the only thing that will shape the future. My concern is that in terms of funding in the future, that Glossop may well lose out. And I know nobody can say to me that will happen or that won't, but I just think, I mean, I also am concerned about, and I understand with the pandemic and everything, maybe I've been out of touch, but I've spoken to many people who haven't got a clue that this is happening in terms of, so I think there is an issue about how it's communicated to the general public, because I do think that certainly I live in Glossop, and I don't think people know about this, and not as many people know about it, and I think it will raise major concerns to people. I mean, it's a fait accompli in terms of there's very little we're going to be able we can do about it now, because I think the decision was made over 12 months ago. But I do wonder how people in the Glossop area can, how we make sure we have a voice, and that things aren't just decided, because we know that a lot of the time, I mean, people who make decisions in central government, have never been further than Watford. So, we've got, I just think, A, there are concerns about it. B, I'm concerned about the language of no change for 12 months. That's reassuring. And then what? I want to know the and then what before I get to month 11. And I think it's about how local people are told about this. I mean, it may be my fault and I've been burying my head in the sand, but it just surprises me that so many people don't know once you mention it. I don't know if anybody else locally feels that, but I'll shut up now. Okay.
Thank you. Thanks for your points there, Linda. And you mentioned in there, and I think it was you picked up the other element of John's question, which was about consultation. Was there a consultation? And you're right that there was. I think it was a nationally led consultation in the pandemic. So I guess the normal means of engagement and local communication probably will have been constrained by that. But there was a formal consultation about all of the national the changes across the country. Let me just check. I think Leslie, was it? Oh no, sorry, Linda. I've forgotten Linda. It's because I've not got your face on screen. Linda, did you want to come in? Oh, sorry. No, it's because your hand's still up, Linda. I've gone back to my list and I'm getting myself confused. Leslie, please come in.
Thank you. The consultation was rubbish. I don't think anybody can say that was a proper consultation, but we'll bypass that. I think one of the things that is going to be concerning people in terms of how we get to know about things is, and we've talked about this through the work stream, I know, and that is trying to make sure that we have visible access to the public and they see us around a lot. So we have got some strategies in place, and it might be worth mentioning here that we're looking to have monthly events in Norfolk Square, where we will have representation from Joined Up Care Derbyshire and from the transition work stream, along with those of us from Glossop Dell who are also doing work here. So we're looking to that, and hopefully that will work. I suspect one of our other issues might be how the GPs feel about this. And I know I've got Vina on the call, so I'm hoping Vina might be able to come in here and give us some light on how you're feeling about this and how you propose from the PCN perspective to join with the community, with the neighbourhood team, and for us to be working together a bit better.
Thanks, Leslie. How are GPs feeling about it? GPs are very positive about it because we believe that every change, gives us opportunity. And like Jess said earlier, there's no reason why we won't be able to keep the good things. And there's no reason why we wouldn't reconfigure services, etc., which are good in Derbyshire and take that on board. So I think it's an opportunity more than a threat. So, and obviously the key thing is to be, like John said, some earlier speakers said, that we need to be really involved in, after 12 months what. So be involved in the process. And I'm closely watching the space. I'm being involved. I've been asked to get involved by Derbyshire. So I think there's no reason for me to be concerned at this moment at all. And I had a talk with the PPG earlier last week, I think, and I conveyed the same thing. Listening to the audience right now, I think I've made notes for myself, and definitely the plan of this monthly event sounds really good, and this gives us opportunity to talk to people directly and allay some of the anxieties that they have. And I think this is a note to myself that I'll be getting involved very closely with the events that are being proposed, as I've got all the details now.
Thank you. Could I just add one other thing? Sorry, I don't want to hog the space, but this is about the people, and we're never going to get a reduction in the demand on primary care and secondary care if we don't get the people committed to making better choices. So we have to start from there. It's got to be about the needs of getting our communities engaged and on board. So we can't stop thinking the demand is secondary care. We've got to look after that first. That sometimes that might be the case, but not at the expense of trying to continue with this work to get this on board. Because if we falter with it too often, the public will get fed up and they won't join us. So we've got to use this opportunity.
Yeah, and also I've taken a point from an earlier speaker from Parkinson's UK, that, I'm not aware of this, the frontline staff. I wasn't aware of this frontline staff not giving a consistent, reassuring message. So this is, again, a to-do job for me, that at the very earliest, I will have a meeting of some kind with all the frontline staff to see that we are consistently giving the correct message that we have to date. So hopefully that should happen. We have a primary care network board meetings, and through that, I will be organizing that pretty soon. So I think that in combination with the events that we are planning, Norfolk Street events, I think we should be able to give a consistent and correct message to the public, and obviously engaging with them is the key to the successful transition and keeping everybody on board with it. And I'm open to any suggestions from Leslie and anyone. Everybody's got my email address, my phone number. Get in touch directly if you don't. Leslie can get into the public domain more than I can, and I'm happy to work alongside.
Thank you, Veena. Thank you for that, and thanks, Leslie, for flagging around those events as well, because I think that point that Linda made about that communication and whether the communication and the level of engagement and that national programme was right, we could discuss and debate, but we are here now and we're having these and really wanting to hear. And I can see as well in the chat the point that was made, I think, Sonia, about the CAMS and concerns around that services. We've perhaps not got anybody on the call at the moment who could respond to that, but it's for us to note those sorts of concerns and issues and to reassure people. And similarly, they can just assure you that the Bureau are involved in the discussions, and there's some really good, the High Peak Local Place Alliance, so we work in sort of in your neighbourhoods. We've had local ways of working, and the High Peak Place Alliance are really excited because their population, as we've said, do use the services now, and they feel like they've got more weight and more focus and be more influence in some of those services, because they're connecting with people who are much more closely have historically worked. And so there's real opportunities to bring some of those partnerships that support improving health, and as Helen was saying, some of those things that really impact on people's health that aren't about health services, and bringing those together in terms of working across that boundary, the connections in the High Peak, and working really drawing on all those really strong partnerships. So that's the bit that's going to really make the difference, I think. Andy, did you want to respond on that before I bring in Irene is the next question?
If that's okay, thanks, Kay. It's just a really brief comment, just an assurance from me really on behalf of comms that we'll be doing our absolute damnedest to reach people in every way we can. We've just said particularly Vina and Leslie, how important it is we have that engagement, and we'll keep pushing it. Leslie and I were only talking about it yesterday about what else can we do. So it's just really important that we try every channel we've got, and we will keep doing that. So just an assurance from a comms perspective that we'll be on the case. Thank you.
Thank you. If I can bring in Irene, do you want to raise your question?
Yes. Well, mainly it's the sort of thing that Leslie has been mentioning. I think initially the communication was not very good at all, and we've got to get that right. And it sounds like we're going to be getting it right. I just wonder why we've not used the local press and things like that to do probably the things that you put up on the screen, just to let the people know. And I agree with the other lady that mentioned a lot of people don't know this is happening. I only know because I'm on the patients participation group, and it would be nice if there was a little bit more happening. But listening to Leslie, it sounds like we are going to get things moving now, which is good.
Thank you for that point, which and as I think it was Lee that said, it's really useful to hear when people reinforce points as well, because we know then that that we're really hearing then what the key issues are. So that continued really local engagement and using all those resources possible, and if there is a local newspaper, local press, I'm sure Andy and the team would be quite willing to link into that and provide some information for that if that's not already happened. Lee, did you want to comment on that?
Yeah, I had on that kind of myself and Andy actually had a conversation about this last week, and talking about the media and things like that, and in all the different ways that people can get in touch, especially people that may be virtually excluded, as we're having a virtual conversation tonight. We're kind of treading, it's difficult in terms of we're treading something of a fine line when it comes to media, press media, of saying nothing's going to happen for 12 months, or there's very limited, versus actually it's getting blown into it's been spun into a media story of everything's changing sort of thing. So we are broaching that subject. We have kind of put feelers out to the press, and we're managing this conversation. But just back to your point, Kate, before, about it's very useful to hear off people, off everybody, as to any mediums that we can use to kind of take that conversation on. I've put a long rambling message in the chat to that effect. So yeah, the media is something that's on our radar, and that we're in contact with, and as to how best broach that. But we're also mindful that we come across with the correct message that gets across to people in the correct way, because these things are, we're on a call now, and they can be kind of be sensibly handled and promoted as such, as we have done, and we just want to make sure, in conjunction with the press, that what we're saying is what we mean and is what's happening, rather than something that might be sensationalist.
Thanks, Lee, that's really helpful. Can I bring in Josh?
Yeah, I work in a crisis mental health team for older adults in the High Peak and Dales, so I was aware that there's this change happening, but I suppose this is the first time I've been able to get into one of these meetings. I just probably wanted to pick up on something that John said at the beginning about where people go for hospital and patient choice. In a mental health team, sometimes you end up where people are detained under the Mental Health Act, and you still try and give people as much choice as possible. However, to this day, I've not actually been successful in admitting anyone into the Stockport side because it's under a different trust to us. So people that do require admission, we cover up sort of Buxton, New Mills sorts of areas. Unfortunately, I've had to go all the way over to Chesterfield, and from speaking to the individual and families, it's such a trek for them. There's no direct route. You're talking a 2.5 hour journey just to go and see your loved one in hospital. And we do have some commissioned beds with Stockport, but they don't, because you can't keep beds empty. If we're not using them, they get filled up. And I suppose we have very good ties in with our inpatient areas that, we gatekeep and manage those beds. So if we know that someone needs to come in, we're thinking, who can we support out of hospital, where, because we don't have that with a different trust, you know, if we feel there's a need for a bed, I don't know whether there's that same urgency, or there might be different priorities for them and people that need to go in. So I don't think it's as clear cut as what was put across as, you know, if someone needs a bed, they're given a choice of where they go. You know, in mental health, you don't always have that freedom of choice, unfortunately. So I suppose my concern would be that we might be seeing people up in Glossop eventually that might need admission, and they might be going over to Chesterfield. I just wondered if there'd been any consideration about how that would work.
Thanks, Josh. Really important question, and I'll bring in Jennifer to respond to that if I can. Thanks, Jen.
Yeah, not a problem. Yeah, I think you raise a really valid point, Josh. What we have seen is that we've had real issues in accessing the Greater Manchester beds from Pennine Care for a while. I think they've reduced their bed base, and we have issues in making sure that the Derbyshire flows in. Now, we are in conversations with Pennine saying quite clearly that the Glossop patients who are accessing beds should continue to access beds. So exactly as we said right at the start, we're having those conversations with Pennine Care to say, actually, we need to make stronger links, and the population should still be able to flow into those beds. We do appreciate the pressure on their beds. We in Derbyshire have similar pressures, as you'll know, on our beds and in terms of demand. So I think it's a really, really valid point. We are making those stronger and closer links with Pennine, and now that we've got a greater, as Kate was saying, kind of the high peak, now we've got a greater population base, we should be able to have a little bit of a stronger voice around the table with Pennine. But what we are quite clearly saying is, just because the Glossop population will come under Derbyshire, that doesn't mean that they should flow into our Derbyshire beds. You're absolutely right about in certain cases where a mental health act is put in place, and under certain legal requirements, people will need to get access to the nearest bed that they can that's available. And it may be that someone does get admitted into Derby or into Chesterfield because that's where there is an available bed. What we would be wanting to do is make sure that those patients get home or get repatriated into a closest bed as soon as possible. But yeah, I think we are having conversations with your operational leads, with Ade and with David Tucker, to make sure that we're making those strong links, but also we are keeping that flow into the Pennine beds as we know that we should do for that population that looks northwest, actually, isn't it? It's north for me, but northwest.
Thanks, Jennifer.
Yeah, thank you. And I think that flags the fact that some of these things are challenging now. You know, we've not got a perfect system in any part of the patch, and we're continually trying to review and improve. And some of these things are really challenging and don't always give the experience for individuals that we'd want to. And I think that's what we constantly strive to identify. And I think any of those risks around the impact of this that could potentially cause any of those greater problems, those are the things we're trying to identify and come up with plans and approaches to reduce the risk of that, and to have contingencies and options. So and I think it was the point that Linda made earlier about, you know, nobody would want to give any false promises to people about the challenges of service delivery generally, but we really do see this as putting in place the opportunities, particularly for some of the longer term changes that are coming through nationally in terms of integrated care systems, where the focus will be on really aligning health, social care, local systems and population health across those sort of health and well-being broader areas that it will position us within Derby and Derbyshire, including Glossop, to be in a really strong position to make the most of those as they emerge. And they're not all apparent at the moment, but it will be we won't have any issues because Glossop's in a different part of the patch. We'll already have got that set up. So I'm looking around for any further final hands. We've got another few minutes left for any final questions, comments, but we won't drag this out. I mean, I think, and I hope people have heard that you know, it is very much an ongoing. We do want to find different ways, and a really important point made right at the beginning about the staff role in that. You know, staff are seeing people all day, every day, and so it's an opportunity for us to hear where there are concerns and to make sure there's reassuring messages. That was really helpful to hear, as well as obviously all the comments we've heard today. Leslie, did you want to come back in?
Yeah, thanks. So just like sort of from my point of view and working with the joined up care team, I do believe that this conversation is very genuine and will be ongoing. So I would like to give the people some reassurance there. The other thing that's really, really important is that you're being asked what it is you need. And Andrew's just said, we talk very frequently about what else can we do, but we don't know what it is you want or need unless you tell us. So please, please feel free to drop lines and emails or whatever to any of us, and so that we can try and put it together to get the best for you. Thank you.
Thanks, Leslie. That's really helpful, and I think the more ears we've got out there listening, and the more voices we've got, the more we will be able to collectively shape this and make sure we identify risks and address them, and then really draw the opportunities and the learning. And as I say, from the work that I've seen and that's already going in Glossop, there's so much really good stuff to be built on and to be learned from, and for us to continue to strengthen. Any other final comments? I know, I'm sure everybody's got things. Well, we know some people from chats right at the start of the call, or for anybody that was on right at the beginning, there's some people with some plans for the rest of the evening. So thank you very much for committing your time in an evening, and hopefully we're trying lots of different ways to make sure we are giving people opportunity to feed into this, and recognizing it as well, the fact that people have to have digital access. So we are cognizant of that, and trying to make sure that there's ways people can access these conversations, even if they've not got that facility. So thank you very much for your time. Thanks everybody as well on the panel, and to Jess as well for supporting how we take this forward, and ongoing conversations. But thank you very much, and good evening. Bye bye.
Thanks all. Thank you.
Thanks very much.
Thank you. Bye bye.
Bye bye.